Hello everyone. Today my presentation focuses on infant of diabetic mothers, referred to as IDM. I will walk through the underlying pathophysiology, the complications that these infants face, and the approach to management. Understanding this topic is essential because maternal diabetes can have profound short and long-term consequences for the newborns. Let's begin with the incidence. Infants of diabetic mothers represent a significant proportion of neonatal intensive care admissions, and with increasing rates of both gestational and pre-gestational diabetes worldwide, this problem is becoming more common. Awareness and proactive management are critical to improve neonatal outcomes. About 1 in 5 live births globally are affected by hyperglycemia in pregnancy. The global prevalence of hyperglycemia in pregnancy is rising alongside increases in the prevalence of obesity and diabetes. The IDF, that is the International Diabetes Federation, estimates that almost 19.7% of live births in 2024 were affected, with almost 79% of cases due to gestational diabetes mellitus and 20% were due to combined overt diabetes in pregnancy and pre-existing diabetes in pregnancy. Here we see the core pathophysiology. As we see that when mother has high blood glucose, that glucose crosses the placenta and causes fetal hyperglycemia. In response, the fetal pancreas produces more insulin, leading to fetal hyperinsulinism. And this insulin acts not only as a regulator of glucose but also as a growth hormone, which results in macrosomia and organ enlargement. And chronic exposure to high insulin also drives metabolic complications that I will discuss further. This slide highlights an important concept, that is the effect of the timing of poor maternal glucose control on the outcome of the newborn child. Poor control, as we see, if it is present early in pregnancy, is linked to congenital malformation and growth restrictions, because in the first trimester the organogenesis is taking place. So if the maternal diabetes control is poor, that will have directly effect on the growth of the child and the organogenesis and will lead to congenital anomalies. In the second trimester, it can cause complications such as hypertrophic cardiomyopathy, polyhydramnios, preeclampsia, even fetal loss. Poor control in the third trimester increases the risk of macrosomia, hypoglycemia, respiratory distress syndrome, and stillbirth. Uh, Even during labor, the baby can experience neonatal hypoglycemia and poor ABGAR scoring and may need resuscitation. And long term, these infants face higher risks of obesity, diabetes, hypertension, and renal diseases. This slide, you can see, further summarizes the wide range of complications that these infants can have. This includes congenital malformations, which may include any organ system from CNS, CVS, skeletal, renal, GI, or eye. Then there may be growth disorders, which can present as either macrosomia or intrauterine growth retardation. Then there is metabolic complications, which may include hypoglycemia, hypocalcemia, and hypomagnesemia, for which we need to monitor these newborn babies after birth. Respiratory issues such as respiratory distress syndrome, transient tachypnea of newborn, hypertrophic cardiomyopathy with obstructions can be there, and for this we need to screen these newborn babies. Hematological complications include polycythemia, hyperbilirubinemia, and even thrombosis. As we see that these newborns can be large for gestational age, so they can suffer birth injuries like shoulder dystocia or brachial plexus injuries. Here we see specific congenital malformations pertinent to a specific organ system associated with infant of diabetic mother. If I talk about the cardiac malformations, these newborns can have a transposition of great vessels, VST, truncus arteriosus, hypoplastic left heart syndrome, or PDA. In CNS, they can have neural tube defects, anencephaly, or microcephaly. Skeletal dysplasias may include caudal regression syndrome or hemivertebrae. Renal involvement may include renal agenesis, small left colon, or duodenal atresia. And ocular manifestations such as microphthalmos and optic nerve hypoplasia can be there. This highlights why preconception control of diabetes is so important. Clinical presentation. Clinically, infants of diabetic mother can present in several ways. As I discussed earlier, at birth they can be large for gestation age due to hyperinsulinism or small for gestation age if the maternal vascular disease limits the growth of the newborn. In the early hours of after birth, the child or newborn can suffer from hypoglycemia, which can lead to jitteriness, lethargy, or apnea, and we need to monitor the blood glucose level in these newborn babies after birth. After 24 hours, hypocalcemia and hypomagnesemia can lead to seizures in these newborns. So, meticulous monitoring for these calcium levels and the magnesium levels is very important after birth. Respiratory distress, hypertrophic cardiomyopathy, birth trauma, or gastrointestinal anomalies may also be observed as I discussed in the previous slide. Regarding the diagnostic workup, it includes several important tests, but most important is the blood glucose level, serum calcium level, magnesium level, hematocrit, and the bilirubin level. This should be checked initially. Imaging should be done like chest X-ray for to detect the respiratory distress syndrome or RDS, contrast enema for if we are suspecting small left colon in these newborn, and definitely these newborn should be evaluated with ECG, echocardiography for cardiac malformations like VST, AST, VST, hypertrophic cardiomyopathy, TGAs. So let's talk about the management of these newborn. Management mainly starts with the hypoglycemia. Following the American Academy of Pediatric protocols, we can provide early feeding or intravenous glucose as required. Hypoglycemia is treated with slow IV calcium gluconate with close cardiac monitoring, and for hypomagnesemia, it is corrected with magnesium supplementation, either IV or oral. Respiratory issues like RDS or TTN may require oxygen or even the ventilatory support in very sick newborns. Hypertrophic cardiomyopathy is treated conservatively with beta blockers and with supportive care. Uh, Hyperbilirubinemia, that is managed with either phototherapy or exchange transfusion depending upon the level of bilirubin and the day of life of the newborn. Polycythemia may need hydration, partial exchange if the newborn is symptomatic. For babies, birth injuries like shoulder dystocia or brachial plexus injury, management can include immobilization, physiotherapy, or even surgery if it is required. Finally, the prognosis. Outcome have improved significantly with good maternal glycemic control. Preconceptional counseling and tight control of diabetes before and during pregnancy can reduce congenital malformations and complications. However, infant of diabetic mothers still carry a tenfold lifetime risk of developing diabetes themselves, so long-term follow-up and preventive care is essential. Thank you so much, and if you find this video helpful, then please do like, share and subscribe.